Good morning, and thank you very much for being here today. I know you're all very busy, and I appreciate the time that you are devoting to this conversation. Speaking of being a patient, 2 summers ago, I was vacationing on Emerald Isle in North Carolina and developed an atypical presentation of appendicitis. It's not something you expect while you're on vacation, but thankfully found a great local hospital and was operated on by a retired armed services general surgeon who was practicing in that hospital and recovered well. The only problem was I couldn't fly back to Minnesota and had to drive back to Minnesota after that. This past weekend, I was in Oxford, North Carolina, where my parents, Charlie and Frances Jones, 88 and 85, still reside and are living independently with health. My dad, about a year ago, was on the treadmill at the local fitness club and developed syncope, just passed out right there. And he had critical aortic stenosis. That's the main valve that's leading out of the heart, and was critically very tight. He could have died right then. But he's been successfully operated on here in North Carolina and is back chopping wood and bush hogging out on the farm. So my mom, and it's critically important that Dad is doing well, because Dad is the caregiver for Mom at night. Mom has moderate dementia. We have assistance during the day. But Dad is the caregiver at night. So without Dad being healthy, Mom would be in a nursing home. So what I'm going to tell you about how we need to create a sustainable health system, for me, is both professionally and personally very important. And particularly being back here, I'm honored to be here in North Carolina and to be joining in this conversation with you about how we do it in North Carolina, how we do it in Minnesota, how we do it around our country for the future generations that will follow us. Let's see. Oh, here we go. So before we begin, I want you at your table, there's some 3x5 cards. So I want you to each take a 3x5 card, and I want you to write on one side what health means to you, and then flip it over on the other side, write what health care means to you. Now, it might be a definition, it might be a word, it might be a phrase, it might be a story, it might be a symbol, but one side, write what health means to you, and then the other side, write what health care means to you. So lots of things that health and health care mean to us. And you heard words about being independent, being able to live life to the fullest, family. When I'm sick, doctor visits, where's the prevention in health care? So there are lots of things that health and health care mean to us. So today, I wanted to just spend some time helping us understand some of the issues that are in health and healthcare, to illustrate some frameworks for change. I think you kind of heard that hinted already in what's coming, and you know that, you're living the change. Explore elements that I think are essential around trust and community for change, and then propose how community stakeholders can really work together on a sustainable health system. So what are some of the pressing issues that we're really facing today, or the changes that are going on? So I'm really going to dive a little bit deeper into the challenges. So this is kind of the bad news first. Certainly you've seen and you already heard about the international comparisons that we have in thinking around our system when we compare to other developed countries. And if you look at our country, we have the dubious distinction of being the highest expenditures per capita. And yet when you look across the domains of quality, access, efficiency, equity, even long, healthy, productive lives, we often come in dead last, no pun intended. There is nowhere when you compare us to other countries that we even score in the top 3. Some could argue we've really gotten the balance off between health and healthcare and how we actually put it together in our country to get the results that we all want for our families and our communities and our children and the people we live with. If you look at what this situation is doing to our federal budget, if you look at this goes out to 2040, and you see that people say in Washington, D.C., we don't have a budget problem, we have a healthcare problem. You can see that the increases here in government outlays are going to be driven by Medicare and Medicaid spending, which then increases our fiscal debt. So this is not just happening at a federal level. If you take it down to at least in Minnesota, we have a health economist in our state whose job is every year to figure out how much we've spent and to keep tally on it. And you can see that we've had an inexorable rise from 1999, $17.6 billion, up to 37.5. And so it's more than doubled there in about 10 years. So it's clearly an unsustainable rise as you look, at least you drill down to one state, and I would argue probably North Carolina is similar to Minnesota. If you look at what was just in the paper, USA Today last week, and looking at what's happening with healthcare cost and the increase in the first quarter in 2014 with healthcare spending being up. So those of you who thought maybe we were turning it around, I think we need to take a deep breath with that. One of the things with this increasing rise in healthcare spending and healthcare cost is that the percent of adults who went without care because of cost, and comparing 2007 versus 2012, and you can see North Carolina right here, and in almost every place from 2007 to 2012, people who are going without care because of cost. Now you can argue, well, maybe some of that care wasn't needed. Maybe that extra MRI for the back pain wasn't needed, or the antibiotic wasn't needed when it was just a viral infection. Yes, there's waste in the healthcare system, and there's stuff that we don't need, but cost or just doing, co-pays, et cetera, is a very blunt instrument. And some of the things that people went without were needed things. They were their blood pressure medicine. They were their mammogram that they needed to get. So this rise in costs is actually causing us to maybe not get care we didn't need, but we're not getting care that we did need to stay healthy for our family and our community and to be able to live long, healthy, productive lives. This is a slide when I was Commissioner of Health that the state economists that really marked on my brain about the challenge that was here. And this was looking at the next 25 years. This was in 2008 and looking forward for the next 25 years. We were in budget deficits then, but the state economists said Minnesota was going to get back to a positive revenue state. But healthcare costs were going to go up, and you always have to be careful with percentages, but we're going to go up at a rate that there was going to be little additional money left over without doing additional taxes or revenue raising. Little additional money left over for education, for roads. We have to fill all those potholes in Minnesota every year after all the horrible winter that we have. So roads, and you know what happened with bridges in Minnesota? The 35W bridge fell down a mile from my house. Parks, trails, job development, affordable housing, all the things that we hold near and dear in a community that we were not going to have additional money. So why is that so serious? Well, if you look at what makes us healthy, if you really look at what makes Eastern North Carolina healthy, it's estimated that only 20% of what makes a population healthy is access to quality health care. The other 80% is outside those doctor visits. It's outside those clinical walls in what makes a population healthy. So it's the health behaviors, tobacco use, being physically active, eating nutritionally. I love the fact we had calories related to what we were eating this morning, alcohol use, unsafe sex, socioeconomic factors. You know, how many people are graduating from high school? How many are going on to secondary education? Do people have a job, or are they living in poverty? What's their social support, the community support, and then the physical environment. So it's this other 80% that makes a population healthy. But what's happened in America right now, and you just saw what's projected for Minnesota, which I suspect is also happening in North Carolina by some of the papers that I read, that this 20% is gobbling up more and more of the budget for these other things. And what can happen is that as this takes on more and more, and it takes money, I say robs, from these other social determinants of health, things that you can modify, you get into a situation where the population becomes less healthy, which means you need more of this, which means it costs more, which means you take away from these other things, and you create a death spiral. So you actually create a death spiral where population gets less healthy, costs more to take care of them, you rob from the other things, which means the population gets more unhealthy, which means it costs more, and it's a death spiral. So how can we begin to think about it differently and say, how do we get out of that death spiral? This is North Carolina's roadmaps, county health rankings. How many of you have seen county health rankings or are using them in your work? All right, a number of you. So you know when you actually take, and this is broken down by county within a state, and they actually look at outcomes. So what are the outcomes we want? And one of the outcomes we want is to avoid premature death. We want to stay alive for our families. We want to stay alive for our grandkids, be functional. So they look at outcomes like that. Birth outcomes, they look at quality of life outcomes. And then they score them for each county. And then they also look at the upstream issues that you just heard me talk about. The upstream issues, so the health factors, saying, you know, how are we doing with our health behaviors? How are we doing with our education? You know, how are we doing with poverty? A number of the factors that are going to produce those outcomes, that are more linked to those outcomes than necessarily healthcare. Healthcare is an important factor, don't get me wrong. 20%. Controlling blood pressure to prevent stroke. You guys are in the stroke belt. Controlling blood pressure is a very important issue in healthcare. But we also have to remember these other factors that keep a population healthy. So this is a great tool. If you haven't used it or been looking at it, it's not perfect. You need to combine it with other community assessments and other ways of thinking about it. But it's a great tool, and it's out there, and it's populated and updated every year for your use. So North Carolina is making progress, and I think you should be commended for that. This is from the Commonwealth scorecard on their state health system performance in 2014. North Carolina is improving. I think it's a great place to build on the assets that you have. And I think today, as Dr. Herman said, it's the beginning of conversations of how do we continue to build on what we have for the challenges that are in front of us. So I want to just show you a little video that I think encapsulates some of what I just told you about some of the challenges, but also the hope about what conversations like this can bring. So.
Pie charts aren't the most interesting things on Earth, but this one is an eye-opener. Did you know, if you look at all the variables that contribute to the public's health, only 20%, only this much, is healthcare? You know, doctors, hospitals, surgeries, all that. The vast majority of what actually keeps us healthy, from diet to education to housing to smoking prevention to jobs, all that stuff is over here. But there's a problem. The cost of this is doing this. Not good. You see, in recent years, the healthcare industry, both here in Minnesota and across the country, has been focusing on three main goals. They call it the triple aim: health, care, and cost. The theory is that if we pay attention to these three factors in a balanced way, we get the best possible outcomes: healthy people, manageable budgets, and a better quality of life. But creating this balance is almost impossible when the foundation is doing this. So how do we fix it? According to the experts, one of the big challenges is the way we talk about health and healthcare, or more accurately, the way we don't talk about them. For example, nobody likes to discuss the price of treatment. Not patients, not doctors, not families. After all, when someone's sick, we shouldn't be worrying about dollars and cents, and yet, at the same time, there's a lot of research that shows more treatment isn't always better. That's why a coalition of organizations is starting a conversation between the people who need care, you and me, and the people who provide care, also you and me. You can see a common thread here. No matter what you think about healthcare today, this entire system is funded and maintained by us. Not you and not them, but us together. And if we don't find a way to figure out this, we're going to crowd out a lot of the other things we depend on. The next step here is a tough one, but it's not impossible. We need to start talking. And that's what today is all about, starting a conversation with everyone involved. Because hey, we all want the same thing here, and that's a healthy tomorrow. So let's get to work.
So one of the things you heard in that video is about a framework. And that's some of what I want to talk about now, is some of the frameworks that you can use in your conversations to keep you grounded. Ones that we've been using in Minnesota and I think are being used nationally. And the first one is the triple aim that you heard. It was coined by a number of leaders at the Institute for Healthcare Improvement, national organization, in thinking around how do we need, if we want a better system, we need to do three things simultaneously. Improve the health of the population, improve the experience of care. People assume quality, so we need to be improving quality, but we need to be thinking about what's that experience of care like for patients and families. And then the last one, they always said decrease per capita costs. In Minnesota, we like to make them all positive, so we made it improve affordability by decreasing per capita costs. So that's a framework to say we need to do all three of them simultaneously. There are people who are going to want to work just on the cost, but you also got to be thinking about the health. You can't be doing things over here about cost that are going to be detrimental to health. And you got to be thinking about the patient experience, but you got to be making certain that you've got really good quality as you move forward. So that's one framework that's guided us and is actually in the National Quality Strategy about how to think about what you're going to do to improve in all three areas. Here's some of the things that we've been thinking about, the components inside that healthcare part and how to do that. And we've talked about how you've got to think population-based outcomes. It's no longer enough to say, I'll just take care of who comes into my office. You need to be thinking about who's that person who might come into your office, or who's the person who's not coming into your office that ought to be coming in to see you. So how do you begin to think population health outcomes? And it's really more than population medicine, which is just panels of patients, but to be thinking about who are we serving and how do we make certain we're thinking around all the people, whether they come in or not. Co-creation, thinking about how do we do this with the people that we're serving, and what does that look like, and how do we open ourselves up to hear things from them that maybe we didn't want to hear, or maybe it challenged some of our own ways of being. Team-based care, I think you've all heard that about how we really need teams of people being able to put things together. We have a Healthcare Innovation Award from CMMI, from the federal government. We were one of the first 107 to receive them in the country. And the whole thing is about creating systematic case reviews and thinking around how do you bring a whole team together with some of your most complex patients to think about on a regular basis, where are they against goals and how do we create a different path. But it's a challenge. It's different roles for people to play in the healthcare system than we necessarily have played before. And what does that look like? And how do we involve patients and families in it so that they know they're getting good quality and we're creating a great experience for them. And then we need a sustainable business model. The current fee-for-service model is slowly dying. It's dying a little bit slower than we wanted it to die, to actually give us enough flexibility in how we can put together these new models, these new teams. But we've got to create that. And it's one of the things of how do we get from our current ways that we're being paid in fee-for-service to actually get to more global payment for population health outcomes. What will that look like? What's the transition? As you heard earlier, you've built a very successful model based on the past, but the future is not going to look like that. And we're going to have to figure out what are those different business models that actually get us the outcomes we want at a cost we can afford. And then leadership, looking at, there's not only technical things that need to be done, but there's what about the culture and the attitudes and the values and beliefs, and what does that look like that's combined with all the technical protocols and guidelines and pathways and devices and so forth. How do we blend these together? And then the measurement. Thinking about how we're going to measure across all three domains of that triple aim. You're already, at least in Invited Health, you are on your way in looking at that. You were just the recipients of an Eisenberg Award looking at quality inside your hospital. It's a very prestigious award across the country. We were actually there with you as a partner. ICSI received one for its work on readmissions, on decreasing readmissions in Minnesota, and you received one for your quality in your hospital. So I know you're on this path. It's a long journey and you're having to constantly be working at it, but you're being nationally recognized for what you do. But it's not going to be enough to sit on those laurels, as we keep saying in Minnesota. We have to keep working. So we've been working on decreasing readmissions in Minnesota. Our board and leaders have now said, how are we going to decrease admissions, preventable admissions? That the person, if we've given them good care in the clinics, if we've taken care of their needs at home, if we tapped into the community resources, they wouldn't have had to have come to the hospital in the first place. A kid with asthma, if we had worked with the school nurse, if we had done other things, and I know you're doing some of those things here, how can we actually keep that kid out of the hospital and in school and play on the playground and doing things that kids need to do? But as you think about that, that's coming right up against the business model that's built on admissions to a hospital. So what's that going to look like? And how are we going to change that? And what's that transition that needs to happen as we work on getting better health, better care, and lower cost? One of the things that came in the New England Journal that really hit me was this article that asked, what business are we in? It was written by Ash and Volt back in 2012. And they said, what business are we in? The emergence of health as the business of healthcare. Now, healthcare is part of health. You've already seen that, so it's an important component. We're not saying that it's not needed, but what's the overarching vision that we need to have? And in the article, he uses the company Kodak as an example. How many of you had a Brownie camera growing up? Okay, and it used film. Kodak was very much known for film and the chemicals and everything that went along with their industry and with their business model that they had created. 1975, Kodak actually developed the first digital camera. They actually developed the first digital camera. But their company executives said, hey, this doesn't fit with our business model. We sell film. We sell chemicals. This isn't going to work. Why would we promote a digital camera? Well, meanwhile, their competitors came in, did promote a digital camera, and guess what? Kodak filed for bankruptcy in 2012. There's a lesson to be learned here for healthcare. What business are we really in? You can argue we're in the business of health and well-being. Healthcare is a part of it, but the real business is health and well-being. One of the things that is good, I think, in thinking about how are you going to create new mindsets, and that's something that Tracy Johnson said to me earlier here today, is that we're going to have new mindsets as we move forward. Theory U is one of the ways that we have thought about how do we create, it's written by Odo Sharma. It's a pretty dense book, but it's a really good book. And the subtitle is Leading from the Future as It Emerges. A couple of us were talking earlier this morning and saying, boy, if we just knew what the future was going to be, we could build towards that. We could go towards that. Well, you know, we don't. And we don't know how this is all going to work out. We don't know what CMS is going to do. We don't know what is going to happen in our state. We don't know what all the different things that are going to happen in business and everything that's going on. But we can get ourselves open to possible scenarios. And so one of the subtitles here is Open Mind, Open Heart, Open Will. And one of the things he talks about, often there's a challenge in front of us, and you already heard plenty of challenges. We want to find the solution and just go implement it. But when you have very complex problems like we have in healthcare, it's not that easy. So for example, when Larry Schultz, who's the CEO of the hospital in Fergus Falls, Minnesota, said, we got a huge challenge in how we're going to have a rural health model that works. And I think the average age of people over age 65 in Minnesota is like 12% right now. In Fergus Falls, it's 20%. So he's sitting there thinking, how are we going to create a rural health, notice he didn't say healthcare, rural health model that works. One of the things that he did was he told his board, he said, we're going to focus on creating a rural health model. We are going to have some community conversations about how to do that. And you know what? We're going to hear things we don't want to hear. And we're going to hear things we don't like. But we need to broaden our thinking. We need to deepen as we sit there and listen to what people really want and what people really need versus what we can give them. And so he brought together in his community, very similar to what you're doing here today, and started saying, how are we going to create goals on all three parts of that triple aim? Health, care, and cost. And what is that going to look like? And everyone from policymakers and business people to public health to schools to his clinicians, and saying, what are we going to do to create a rural health model? Not jumping right to a solution, but saying, how do we get to a common purpose? How do we get to a shared perception so that we can get to collective action? If you just try to go straight to here, straight to action, you haven't gotten to that common purpose and common place. So when he's brought people together, a citizen could say, look at the data and look at what was going on and say, you know what? We've got a problem with end of life and how we're taking care of people in the end of life here, in our state and in our county. And how are we going to do that differently? And then while he's saying that, the oncologist who's sitting at the table can say, well, we've got a problem in thinking around how we deal with cancer drugs. I've got all kinds of drugs I can use, and I can tell you this one drug costs over $1 million, and it improves life by 10%. It only works on 10% of the people. So how do we have a conversation as a community about what do we want to do? People in our community are not dying in the way that they want to die. Most of them want to die in their own homes, but that's not what's happening. And we're not actually doing things for them that they want done versus what we can do for them. And we're doing it at an unsustainable cost. They're getting to a common purpose. No one but them can tell them what that ought to look like in their community. With their values and their norms and their resources, the federal government can't tell them, state government can't tell them. It's got to be done locally. It's got to be done locally. So as they get to a common purpose, they're now in their third meeting. They just had it last week, third meeting of coming together like this. From that, they're creating new thinking, new mindsets, new activities, and then if new structures are needed to get to that place. So this is a framework that I think is useful for how you think about where you go next and how do you create effective solutions for very complex problems that we're in. One of the things I believe is an essential ingredient for thinking about how are we going to go down that U, so how to actually go down this U is trust. So trust is absolutely critical to thinking about how are you going, when Larry Schultz said, we're going to have these community meetings and we're going to hear things that maybe we don't want to hear. He had to have tremendous trust with the community in order to open up and be vulnerable and for people to trust him and to talk and for him to listen in that piece. So I believe to actually work on these difficult challenges for where we are now, that trust is really essential. So I want you to turn to the person beside you, maybe a different person than the last person you talked to, and talk about what is trust to you, what does it look like to you, and I'm going to give you a minute and then just ask for a couple of you to shout out words or phrases that came to mind. So turn to another person and what is trust and what does it look like to you? So what does trust look like to you? Give me a couple of words.
Reliable.
Reliable.
Safe.
Safe. What else?
Transparent.
Transparent.
Dependable.
Dependable. Competent. What else? Honesty. What else? Relationship. What else?
Unconditional.
Unconditional? Unconditional. Anything else? There are lots of words.
Respect.
Respect. Others? Security? Security. Consistent. True? Truth.
Unselfish.
Unselfish. Great words for trust. Reliable, safe, transparent, dependable, competent, honesty, relationships, unconditional respect, security, consistent, truth, and unselfish. So I want you to think of someone that you really trust. Might be somebody at work, might be somebody in your family or personal life. So think of somebody that you really trust. Now let me give you 5 factors. You just heard a lot of words about trust. Let me give you some factors that contribute to high trust. And you're going to see some of the ones that you just called out. So competence, commitment, communication, conflict resolution, caring. So how does that person you thought about that you really trust, how do they exhibit those factors around trust? So how are they competent? They get the right information to you, the right knowledge, the right skills when you need it. When you've got a project or you've got something to be done, you know you can count on them to deliver quality, good stuff to you. How about commitment? That they'll follow through. They're not going to leave you holding the bag. They're committed. They're going to follow through. They're going to walk their talk. Communication. If for some reason they can't, they're going to let you know. Again, they're not going to leave you out on a limb. They're going to be dependable. They're going to be transparent with you, even if it means it's tough. Conflict resolution. You can trust that person if there's a problem, that they're going to work with you on it. That they're going to get to a win-win, not in a win-win like I get my way and I get my way, but in listening and understanding and working on a mutual solution that people can know what's transparent in how it was accomplished. And then caring. I can trust that this person cares about me. They're in a relationship with me. They care about me unconditionally. They are there for me. These are factors. Not everybody has all of those, so it isn't like if you don't have one of these, you won't have trust. It's different variation and different degrees around trust. That trust is essential for building and going down that U and building new things for this future that's going to emerge that we don't know exactly what it's going to be like, but we're going to do it together. So really, the next essential ingredient, I think, as you build this trust is really community and going beyond just the clinical walls, but thinking about what's in Eastern North Carolina, the richness that's here, that's beyond just the clinical walls in the community and those relationships and those places where you can work together in partnerships and new opportunities to say, how are we going to meet these challenges that are coming forward? I do not believe the challenges that we have about rising healthcare costs, poor health, and not scoring well in how we're doing for our citizens can be solved inside healthcare. It's got to take a whole community. So in thinking about that, there's one more thing I want you to do, is I want you in groups of 3 or 4 to talk about a time when you went outside your clinical walls or your walls of what you do, whether you're a county commissioner, whether you're a mayor, whether you're a business person, whether you're in healthcare, when you went outside your walls and collaborated with some people in the community. What problem did you solve and how did you go about it? So, and then you can put in what trust made it happen, what trust was critical. So you can see by the couple of examples that you've heard, and I know you shared many more at your tables, that there are things that people are already doing that you can build on, and there are opportunities for other things for thinking around how you can take it even further and deeper. And I think the power of building that trust and the power of the community is how we're going to actually tackle some of those challenges that you've already heard about. So really my conclusions are that, really envision kind of the big picture of what needs to be solved here. And I think the doctor who reminded us of how we don't, how things change over time. You heard about what a CAT scan costs at the very beginning. Also reminding us that things maybe need to look different than maybe how we had imagined them in moving forward. Think about how you communicate why change is needed. I think continuing to remind people that the status quo is not sustainable. We can't keep going the way we've been going, so it has to change. Build that trust, strengthen your roots in your community as you are doing, and do it together to make a difference. My challenge to you as I leave would be based on a poem that Meg Wheatley wrote, and the title of the poem is Turning to One Another. And in it, she said, "Be brave enough to start a conversation that matters. Talk to people you know. Talk to people you don't know. Talk to people you never talked to." So please go forth and build this sustainable health system that all of us need, for not only for ourselves, but for those we love and hold dear. So thank you very much.